Welcome everyone. My name is Jaffer Golzar, interventional cardiologist in Chicago and hosting the webinar today. So a few months ago, we started this webinar series at Avenger because of the challenges we've been having with COVID, and we wanted to continue the educational process and continue to learn and share ideas in this venue. Over the past several months, we've really tackled a lot of really great topics and showed some really cool cases. And this month is no different. So this month we're highlighting the HIPACT study, and Dr. Jon George is going to be covering that. But before we get started, I have a few thank yous to go out today. So thank you to Gabrielle Rugo, who is done a tremendous job helping us set up these webinars, as well as Jeff Monroe. Welcome to thank you to the Avenger team, and we welcome them as well. And I know they've been helping a lot of boots on the ground and helping our panelists as well as our physicians be here today and be able to present. So I want to start by introducing Dr. Jon George, and a great friend of mine, very skilled operator. I know his work very, very well. He did his training at Case Western and then Temple University. He's going to be presenting his data today on the HIPACT study. And then we have two phenomenal operators that I know very well and are real experts in OCT and atherectomy and peripheral arterial disease. Good friend of mine, Dwight Dishman, and Dwight and I were actually one of the pioneers and kind of started some of this work early on in Germany, as well as Jon George as well. He did his training at University of Tennessee and is currently practicing in Memphis, Tennessee as well. Good old Southern boy, just like myself. And then we have Paul Cunningham, a very skilled operator, interventional cardiologist, did his training in Baylor and is currently chief of cardiology at Methodist Hospital in Woodlands. And so what we're going to do is we're going to have Dr. George present his data. He's going to show a really compelling study and show some cases and some really interesting slide deck that I've had a pleasure to look over as well. And then we're going to have a panel discussion later on with Dr. Cunningham, Dr. Dishman, and Dr. George. And we want to open up to all of the audience as well to ask questions, be it about OCT, not OCT, about the study, whatever you want to talk about in regards with limited to peripheral arterial disease. In regards to peripheral arterial disease, shoot a question out. You have the chat function as well as the Q&A function. We'll accumulate all those questions and then start asking those and having a great panel discussion towards the end of the hour here. And so I'm going to go ahead and turn it over to Dr. Jon George, who's going to present the HIPACT study.
Thank you, Jaffer. Thank you again for having me here and being able to present some of this data that we acquired and retrieved from the HIPACT study, and we'll go over that in just a little bit. So the name HIPACT came from histopathologic characterization of chronic total occlusions, treated in this case by directional atherectomy. So one of the reasons why we wanted to look at this is because chronic total occlusions, or CTOs, we know represent one of the most challenging subsets of PAD. The reason why they're challenging is because they have high reocclusion rates, least amount of technical success, although we've had a lot of advancement in technology and skill over time. So the idea and the objective of the study was to investigate actual tissue samples collected within this registry. And these were patients that were treated with fluoro-guided atherectomy without intravascular imaging, so using the Medtronic TurboHawk device. This is one way to externalize the tissue and study the tissue to find what we found. And then to figure out if you could delineate the risk factors that correlate with clinical outcomes. So the outcomes being target vessel revascularization. So if the patient came back for a repeat intervention, figure out if there's some sort of correlation between the tissue that we performed the atherectomy on initially and the outcomes. So to break this down, this was really a pilot study, single center, just 19 patients, 19 different lesions. They're all CTOs. So they were all comers in serial patients. We used Ocelot, which is Avenger's intravascular OCT imaging guided crossing catheter to cross all of these lesions. That way we knew that the passage through the occlusion was intraluminal, guided by intravascular imaging. Following true lumen crossing, the idea was to perform fluoroscopy guided atherectomy, so without intravascular imaging, and then externalize all of that tissue that was collected and study that tissue, and then look at the clinical follow-up of these patients at 6 months and look at TLR and the lesion characterization from the tissue samples. So what was interesting is that there was a lot of adventitia in the tissue that we looked at. So adventitial tissue and thrombus was high. Hypercellular cells, especially within the restenotic lesions, fibrocellular material, a lot of fibrous tissue and lipid-rich tissue. And what was interesting in that all 19 patients that were treated all had adventitial tissue within them, and up to 57% of the entire area that was excised being adventitial tissue, which was surprising. And 16.2% is the average of adventitia that was externalized. So if you look at all of the 19 patients and the breakdown of all lesions, some of them were de novo lesions and some were restenotic lesions. The mean length was somewhere around 15 centimeters, 15 to 16 centimeters. There's the excised tissue weight, the sample of debrided or debulked material, the total amount of tissue area, and then the percentage of thrombus. So we looked at the degree of thrombus within the collected tissue, which was also enlightening, as you will see in the future slides. And then the amount of adventitia area. And so you see the varying amounts, but obviously the instant restenotic lesions had no adventitia in them, but the rest of them, if there was excision outside of that instant restenotic area, there was adventitia within those areas. So what was alarming was that in all the de novo CTOs of those, which were 10 patients out of the total 19 patients, 7 out of the 10 had TLR. So at 6 months, 70% of those that subset came back with reintervention. Within the ISR group, it was 89%, and looking at the all-comers, lumping them together, it was a 79% TLR rate at 6 months. So why is that? Why was it so high? And obviously, these are all CTOs, and so this is where we hope to gain some information based on the tissue that was collected. So if you look at the lesion and tissue analysis, there were 3 major correlates that we found that were tied to the clinical outcome, or the TLR. And these were statistically significant when we assessed them. It was lesion length, adventitial resection, and thrombus. And so let's look at each of those individually. And if you look at them in this bar graph, lesion length in the no TLR group, so the patients that did not have TLR had a mean lesion length of about 100 centimeters or 100 millimeters or 10 centimeters, whereas the TLR group had a lesion length of about 15 centimeters. If you looked at adventitial resection, the no TLR group had under 10% adventitial resection, while the TLR group averaged around 15% adventitial resection. And the biggest difference between the two groups was the amount of thrombus. So the no TLR group only had about 2% thrombus, whereas the TLR group had about 10% thrombus. So what does this mean, and where does tissue characterization or lesion characterization come into play? So we know that adventitial disruption accelerates restenosis. as you cut into the adventitia, get beyond the medial layers, you trigger an inflammatory response. And this has been shown in multiple histologic studies. And here's one from Sanford Burnham that shows stem cell migration once the EEL, or the external elastic lamina, is disrupted, which is between the outside border before the adventitia. And so once you disrupt that, there's an extensive inflammatory process that is triggered, which likely results in the restenotic rates, or the high restenotic rates within those segments. So looking at the right half of the slide, it shows you that once you have adventitia disruption, you have significant restenosis at 1 year. And this is based on other studies outside of the HIPACT that have demonstrated that once you have adventitia disruption, you have 97% rate of restenosis at 1 year versus 11% restenotic rate at 1 year if there is no adventitial disruption. There are obviously other challenges when treating complex CTO lesions. We all know about issues with perforation and dissection of the vessel. Thrombus, not as a thrombotic lesion that you're treating, but thrombosis related to the procedure itself, causing distal embolization. Pseudoaneurysm formation due to excess debulking and cutting into the deep layers, and AV fistula formation for the same reasons. So how does intravascular visualization help? And that's what I'm here to talk about. Real-time intravascular imaging can help reduce this adventitial disruption because you're watching where you go. And if you look at this image on the left, it shows you that the atherectomy catheter with imaging, this is a Panteris catheter, shows you how it was initially directed towards normal vessel. And if you had cut there, you would have easily cut into the adventitial layers. But it allows you to redirect based on the imaging to show you plaque and show you the external elastic lamina and cut up to that external elastic lamina and then stop your cuts right at that position, and allows you to do a more favorable cut without disrupting the external elastic lamina. Trying to play this image, there you go. Again, shows you another image on the right, cutting right up to the media and the external elastic lamina. The concurrent intravascular imaging with this device allows you to image appropriately and even cut eccentric plaque without disrupting the normal vessel. The additional advantage of using intravascular imaging is that you can identify thrombus. And so as the study showed, obviously the long lesion lengths, adventitial cuts, and finally thrombus percentage is what led to poor outcomes. And so the direct intravascular imaging allows you to see thrombus. So the panel in the middle shows you adhered thrombus to the plaque. And when you visualize this with the catheter, you can determine how you want to treat these lesions. If there's excessive amount of thrombus, perhaps your management may change. And unfortunately, the HIPACT study was not, it was just a pilot study to look to see what we would find. This now triggers some thought and, a hypothesis whether treatment of thrombus in these lesions, we've all seen these lesions where there's extensive thrombus within the CTO segment, do they need to be treated differently or concurrently with another modality, maybe a pharmacotherapeutic, in addition to the atherectomy or thrombectomy or thrombolysis and such? Many different options, adjunctive treatments in addition to what we traditionally do in CTOs. And so this again, the panel on the right shows you a live image of cutting through plaque and seeing some adherent thrombus as you're cutting through this lesion, this long lesion in a CTO. And I can't wait to have a discussion with my other panelists to kind of engage their thoughts as to how they would deal with some of these findings on OCT. So combining real-time imaging with therapy allows you to be precise in treating these lesions, gives you enhanced control. You can stop right when you get to normal vessel, preventing any complications from cutting into the medial and adventitial layers, increasing your efficiency because you're just debulking what you need to debulk to an optimal level, and maintaining safety for the patient. So the OCT guided atherectomy with the Avenger allows you this concurrent intravascular imaging while you're cutting through these lesions. And for those of you that are not familiar with the Pantheris catheter, this is the tip of the catheter with the OCT fiber right at the cutter edge, allowing you to image right where you're cutting. On the right panel is the actual image that you see showing you the cutter edge. To the right is the actual window that was cut previously and allows you to rotate the catheter and make other cuts, avoiding deep cuts. And then there's the nose cone that allows you to push your debris that you've cut into the nose cone to collect and externalize, and obviously study if you need to study, or just be having a visual marker of what you've done within the vessel. This is the middle marker. There's 3 total markers. So the cutter is away from the middle marker, and there's an apposition balloon behind the middle marker that opposes the cutter to the lesion to allow you to have efficient cuts. So let's compare HIPACT versus Vision. So some of the preliminary data that we've gotten from HIPACT that I've shown you suggests that if you cut into the adventitia, if you have extremely long lesions, and if you have a high thrombus percentage, you likely have high TLR. So what did Vision show us? Vision was the pivotal study with the Pantheris directional atherectomy catheter with OCT in a subset of lesions. And so we compared this to the Vision CTO cohort. Since HIPACT was only CTO patients, we looked at just the CTO cohort within Vision. And that was a total of 32 patients that were also crossed with OCT guidance. So as far as crossing the lesion, it was done the same way. In HIPACT, the atherectomy was performed with fluoroscopy-guided atherectomy with 19 patients, as opposed to Vision, which was done with Pantheris and direct OCT guidance. And both had a follow-up at 6 months, which is easy to compare. And if you look at the TLR rates just between those 2 studies, you see that the HIPACT had a TLR rate of 79%, with all 19 patients having adventitial cuts. If you looked at Vision, there was only 6.5% TLR at 6 months, which is significantly lower. And it is likely that this is because there were no adventitial cuts with direct visualization. So as we look at this, I mean, obviously, Vision was the pivotal study with the device. There have been subsequent evaluations of the same device in different subsets of patients. So Brodmann did another study with the first generation Pantheris, and Stavroulakis did another study with the second generation Pantheris. And you see incremental freedom from TLR. While the Vision study had 83% freedom from TLR, Brodmann had 88% and subsequently 100% with Stavroulakis. And so there's been incremental improvement with freedom from TLR as the technology has improved, the imaging has improved, and the cutting has improved. And the primary patency at 12 months has also improved over time with advancement of the technology. So when we come down to the key points between HIPACT and Vision, We know that non-imaging guided atherectomy results in greater adventitial resection, purely because you can't see where you're cutting within the vessel. We try to use our best fluoroscopy guidance, but we know that this is a three-dimensional lesion, and without intravascular imaging, it is hard to identify where to direct the cutter. OCT guidance thereby allows you to limit the adventitial cuts because you can optimally remove plaque without crossing the EEL and hopefully reducing TLR as demonstrated in both in the vision study and subsequent studies. If you look at the lesion and tissue analysis from HIPACT, there are three major correlates, as I mentioned: lesion length, adventitial resection, and percent thrombus. And so now knowing that you can go into a lesion and have a predictive TLR rate based on what you see on the lesion if you're using intravascular imaging. So if you see a lot of thrombus and you see you know that you're going into a long lesion length, you want to optimize the treatment of that without adventitial resection, because adding that to the mix is going to increase the TLR rate. And so optimizing treatment based on these three factors would be critical. So I'll quickly show a study. This is an older study of a BTK CTO. This is a patient that had antegrade access in the left SFA, a distal pop occlusion, and reconstitution in the distal vessels of the perineal and the PT that go all the way down to the foot. This was crossed successfully with ocelot pixel, and you'll see that we go down sequentially with imaging guidance, and you will see that again, crossing into the smaller vessels become very less intimidating of destroying the distal vessel by having intravascular imaging and knowing exactly your positioning within the vessel as you go down it. The ocelot catheter is based on a similar directionality with the three markers in the middle, the catheter pointing away from the middle marker. So you're always trying to point the opposite side of the middle marker to the plaque and maintaining the middle marker at the normal vessel to avoid externalization of the catheter. We were able to cross it successfully into the true lumen. We had to redirect it a few times as we saw that our catheter was going towards the adventitia. And so again, allowing you the freedom to look at where you are and know where you are, and then redirect your catheter based on where it's positioned, again, optimizes the final treatment for this patient. And this was successfully treated with that strategy, again, with now Pantheris BTK device, which allows you to take a 6 French device down into the tibial vessels with OCT guided atherectomy, and usually just a single cut along the plaque to debulk it and get good luminal revascularization. So key takeaways: the ocelot CTO catheter with imaging again allows for true lumen crossing through the CTO. Directional atherectomy with imaging demonstrates that lesions are often eccentric. So the idea that you just treat this with balloon angioplasty, again, based on histopathologic studies, balloon inflation in those eccentric lesions cause excess barometric pressure and barotrauma to the normal side of the vessel, again causing the same inflammatory process and disruption leading to restenosis. So again, debulking, the idea of debulking is that you debulk the plaque alone and then treat and optimize the remaining vessel with the operator's choice till we figure out the optimal treatment after debulking. Imaging also allows for final adjunctive treatment, especially if there's a lot of thrombus, to decide how to treat this based on the risk for TLR. So with that, I will stop, and I am happy to open this up and have a panel discussion with our panelists.
Thank you, Jon. That was truly a compelling study, and really builds on the body of evidence that we have, that it's not a one-off that Prakash Krishnan did that showed this high restenosis reocclusion rate at 1 year when you remove adventitia. And, we've kind of been preaching this for years, and your study has truly continued to build on that. And really compelling is the fact that you treated only the chronic total occlusions. And, I used to be a hawker as well as you and Dish and Paul as well. We used to all hawk. And the thing is we were, as as you've shown in your study, we were kind of destroying that vessel. We was, taking out media adventitia, just inadvertently just shaving everything off. And the Achilles heels of what we do is restenosis. And that's what the surgeons unfortunately have on us, and bypass surgery has, is durability. And so we focused on so many things, and we're learning so much. And a study like yours, I really want to congratulate you on a very well done study, continues to show us that there's so many things that go into this process of restenosis. And there's so much that we can do that's probably incremental that we need to do in order to improve patency. So atherectomy, and so you show Stavroulakis study, which is actually Arnie Schwind's study that he published, and that was actually along with DCB. So he did atherectomy and then gave drug. And so now the most contemporary data that we have is we're looking at bypass type results at 1 year. With 93% primary patency. So I'm going to stop there. I want to turn it over to Paul and Paul and Dwight, and kind of get you guys' thoughts on this study. And I have a couple of questions after that. So I want to stop talking for a little bit and let you guys talk a little bit.
Yeah, I thought the data was really impressive. And what I found kind of surprising, we have lesion length, which I think wasn't too surprising, that it is definitely something that's going to be a high risk for restenosis. And I think the presence of adventitia is kind of a game changer. I was surprised that there was as much adventitia as there was. I would have expected it to be less. And then I would have said, yeah, obviously, if you cut outside the vessel, you're going to get some restenosis. But the fact that it was present so much was surprising to me. But it physiologically makes sense. You have adventitia and you use OCT to not cut adventitia, but what I thought was surprising is the finding of thrombus. And the fact that you cut thrombus out and the presence of the thrombus tells us about the lesion characteristic, whereas the presence of adventitia tells us we cut too much. So if you see a thrombus, that is a completely different animal, and I think opens up different modality of treatment. So we like to go in and cut and clean and fix and then look at that beautiful angiographic result. But if we see a bunch of thrombus on OCT or in the material we remove, I think Dr. George is right. We need to consider, well, maybe we should be doing something else with these lesions. You get a long lesion that is full of thrombus, that should lead us to a different type of treatment rather than to cut alone, because we know that those long lesion with thrombus should be high restenosis, even if we didn't touch the adventitia. So that may lead us to a different thing. And I think that's one of the things that I like about this space, is that there are not a lot of rules or guidelines like there are in some other places. This is still kind of the wild, wild west, where we are trying to come up with protocols that make sense. And a study like this is exactly that. It's giving us the data to say, this is what we should be doing for these cases. This is what we should avoid for these cases. And when you see this, you should start thinking of a different modality or a different protocol. So I was very impressed with the data, and I was surprised by at least the presence of thrombus being a high restenosis marker. Yeah,
so totally in the same place as you, Paul, because we were not expecting that. Again, we did this thinking that there were some things that we were going to find. We thought maybe there'd be calcium in there that would predict restenosis. Maybe, the long lesion, like you said, is not surprising. Adventitial cuts, I'm not surprised by either. It is the thrombus that surprised me as well. And what's interesting is also, if you remember the bar graphs that I showed between the TLR patients and the non-TLR patients within those three subsets, the thrombus was the most predictive. So that is really concerning. And I don't know how much thrombus it needs to be before we need to get concerned, but this is I can tell you, and both of you being, all of you being big intravascular imaging users, we all see thrombus. We don't necessarily do anything differently, or I don't, and I'm curious to see if you do anything differently when you do see thrombus, and this just kind of moves you to think maybe you do need to do something, and maybe it's not a lot, maybe it's just a small dose of lytics, or maybe it's just a good quick run of thrombectomy before you do your final treatment. I'm not sure, but it just brings that into question.
Well, I agree with you guys wholeheartedly. We typically run by the old adage that what you don't know can't hurt you, but what you do know can definitely help the patient. And as a physician who was born and raised as a hawker, to speak, you kind of go through there kind of blindly resecting plaque, but you're also blindly resecting adventitia a lot of times. And that's a nidus for restenosis and even thrombosis. And your patient ends back up on your table sooner than later a lot of times. But I don't think I could have stated better than Paul did. Knowing what you're dealing with definitely, I think, leads to a different approach in regard to your treatment of the patient. If there's more calcium, you can appreciate on angiography. If there's more thrombus, then you can appreciate. For me personally, the thing with thrombus is that it's typically a lot more friable and more likely to embolize. So if I appreciate a lot of thrombus, especially in the CTO, I'm much more likely to use an embolic protection device. So I think that the more information that you have, you can utilize that information to better treat the patient.
John, I have a question for you. So, we're going back to this thrombus because I think that's really important. So I wonder, do you think that maybe the thrombus is a marker for higher risk lesions? Maybe something that was an unstable plaque that then thrombosed? Or do you think it's just along for the ride and it's somehow leading to restenosis?
Yeah, so I don't think we have enough data to say which of these it is. Like you said, all we know is that it's a marker. It could be that the CTO is more subacute than a completely fibrosed CTO. It's just that maybe we don't treat all CTOs alike. I don't know the answer to that question, but I think it's a great question. But what we do know from the study, albeit it's a small study, what we do know is that if there is thrombus, then the likelihood of this patient coming back is greater. And it's all the more reason to have intravascular imaging to be able to tell before you do your definitive treatment, after you cross the occlusion, to decide how you're going to be treating that lesion. So I think it's going to require a combination of treatment modalities based on what the lesion makeup is.
Going back to Dishman's point about distal embolization, it's one of those things. I have fellows, and they, I use filters in every patient, and then they read books and texts, and they say, "Well, you should only use it if you have single vessel runoff." And I say, "Why do you care if it's single vessel runoff or 3 vessel runoff? Because if you have distal embolization, if you embolize to 1 vessel, you're still going to chase it. You're not going to let it go because you're like, oh, it's only 1 vessel." So, but, especially, looking at these images and really seeing that, that little piece of thrombus flopping in the wind, and, you kind of cringe. You're like, oh, if you don't have distal embolization, distal protection device, you send that downstream and chasing it. What do you guys do in terms of filter use? We all sit on podiums and stuff, and I see there's like a 50-50 split. Half the guys say filter all the time, half the guys say no filter. So what do you guys think? What is your practice?
Well, I tend to use filters for, I'd say, definitely a majority of my cases, because I think we all know that no matter what atherectomy device you use, you're going to get distal embolization. It's just a matter of how much. A lot of it is contingent upon plaque burden. So maybe for short lesions, I may not use embolic protection. I'll do what I call pseudo-embolic protection, and that's get a wire all the way down into at least one of the tibials. So in case I do need to kind of work my way back, I can. But if it's an extensive lesion, a CTO, I'm pretty much going to use embolic protection every time.
Paul, what about you?
Yeah, I use it every time. And even when I use it every time, every once in a while we do the Gilligan's Island thing where it's the 3-hour tour and we're going down there to chase several emboli that have gone down into the tibial vessels, and I just can't abide having embolic phenomenon, even though I know a lot of doctors say that most of it's subclinical. If someone's coming in with the CTO or chronic limb ischemia and you're doing limb salvage, I can't leave a outflow lesion regardless of how long it takes to get out of there. So because I do that, I filter virtually everything. The only time I take the filter out is accommodating space and length. If the lesion is really close to some outflow vessel and I need to cut as close as I can to that tibial vessel, I sometimes will have to save that to the very end and then take the filter out and continue cutting over a normal wire.
Yeah. John, Paul mentioned that even though he uses filter every time, you can still have distal embolization. I think sometimes it just sneaks by. How do you recover? How do you recover from that? What do you do? How do you retrieve a distal embolic event?
Yeah, I mean, it kind of depends on what you started off with and what you find, how far away the thrombus is. I usually start as the first step. You probably just cross the occlusion and then do some sort of thrombectomy and try to aspirate out of that thrombus. My go-to is now Indigo, the penumbra aspiration catheter. Get powered aspiration to try to get as much of that out as possible. If that doesn't work, then I go to other options. For me, as far as filter use, I'm in the same boat. I've started using filters. I didn't start off that way, but I use filters now almost I would say like 98% of my cases. And like Dr. Dishman, the only cases that I haven't used it in are the really short lesions. And sometimes I regret not using them there as well. So I think it's a smart idea to use them in most cases. The difficulty with seeing thrombus, though, is that you're seeing it either during your crossing phase with ocelot or during your atherectomy phase if you're using Pantheris. But then, the question is, what are you doing after that? Are you removing the filter because you need to treat more? And if you do see thrombus, perhaps you shouldn't remove the filter, or even if you have to retrieve it because there's debris in there and there's slow outflow, maybe it needs to be pulled out and a new filter deployed before you do the rest, because we're not done with the case by then. You still have balloon, and I've had issues like that before, where I use a filter, I have it during the crossing, I have it during the atherectomy, and then I'm like, okay, we're safe for now, and I balloon, and then I go aggressive balloon because I've got partial underexpansion or something, and then the next thing I know, I've now embolized. So you don't want to be in that situation either. So it's kind of making sure you're taking into account all of those issues.
So we have a question from the audience. What about filter use with SV in below the knee cases?
I almost exclusively use Spider, and the Spider embolic protection device goes down to a 3 millimeter. So you can put that, I think, relatively easily in most cases in distal tibial vessels if need be. And I have done that and done it successfully many times. So I use a Spider almost exclusively.
Yeah. We have another question from the audience. I'll ask John about this, and so this kind of relates to your study. So if you see thrombus on OCT, are you more likely to use long-term anticoagulation, or limited time anticoagulation, such as Xarelto?
So I haven't changed my practice yet. This is it's brought up thought, and it's thought-provoking at best. I don't know that we have data to change management from this, and I'm curious to do future studies to look at this, and then perhaps that'll be down the road. I think if I see a lot of thrombus, I'd probably at this point at least do some aspiration, and continue treating the way I do, but keep a closer eye on the patient. And again, you know, I've turned to using OCT guidance for a lot of these cases, so at least I know that I'm limiting the adventitial cuts. So what we saw in this particular study was the combination of lesion length, adventitial cuts, and thrombus affected TLR outcomes. We don't know about each of them individually necessarily, but we know that those are three correlates that are statistically significant. So if you minimize, you know, the adventitial cuts, perhaps you overcome the problem with the thrombus. I don't know the answer to that, but I think I would be more aggressive treating thrombus based on this data than I was previously. I haven't switched my practice towards treating with anticoagulation yet, but it's not an unreasonable thought, especially because you have indication now for PAD.
Paul, so we have a question. So let's say you're treating multiple vessels below the knee. So let's say you have an intratip, occluded, and then you have a posterior tip. You put a filter down, you treat the AT, and now you want to treat the PT. So do you retrieve the filter and then redeploy the same filter? Do you use a fresh filter? What do you do?
I use a fresh filter. I'm not saying it's wrong to retrieve that filter, clean it, rinse it, etc., and then try to redeploy it. I think if you're trying to be very economical, for example, if you're in a private cath lab and you're really trying to cut costs down, I think it's reasonable to reuse some of these pieces of equipment, assuming you clean them appropriately. If you're in a hospital-based cath lab, that issue is less of an issue, the economic side, just because of the economics work out a little bit differently. But I would remove the filter and either deploy a new filter or reuse the same filter. I wouldn't, and I certainly wouldn't put two filters in at the same time. All we need to do is cut one of those wires, and then we're have a whole nother embolic issue going on.
So let's kind of talk about adjunctive therapy. So, you know, this study also kind of makes me think a little bit more about adjunctive therapy as well, because, you know, and the fact that you have OCT allows you to see thrombus and you know, other characteristics that may lead to higher risk of restenosis. So, you know, from my standpoint, most of the time I use drug-coated balloons. I use DCB unless I have a flow-limiting dissection or just an ugly-looking dissection. But I wonder if, you know, looking at this study and the higher risk of restenosis and the concern for distal embolization, as Dish said, I wonder if that might be, you know, something to think about, to say, you know what, if you don't see thrombus, a DCB. If you see thrombus, you want to exclude everything, not, you know, push everything out of the way, and use a drug-eluting stent. So that would be one thought. But what are you guys' paradigms for adjunctive therapy? What do you guys do? Dish, what do you do after you do atherectomy?
I do DCB essentially after every atherectomy case, simply because I've been doing it since the onset, and I've had great results with it. So even when there was a lull in use for obvious concerns, I was still a pretty avid DCB user. And again, I've just had great results with my patients. So, you know, I use a lot of DCBs. I stent as need be, and even with that, I limit my stenting by using tack stents, and I limit it to dissected areas only, and do very limited spot stenting, even below the knee if need be. But my algorithm typically is atherectomy followed by DCB.
John, what about you?
Yeah, very similar. I do a lot of DCB. You know, I did cut back in a hospital setting of using DCBs when there was concern about mortality. I cut back, but I didn't eliminate it. I'm still using them in high-risk lesions and long lesions. I will say that in the really long CTOs, I do tend to stent more than the shorter lesions, but shorter segments of it, like Dwight was saying. maybe the entry, the proximal cap, maybe just the distal cap, depending on what looks ugly, to leave a good result. But I do have some segments of stenting that I do, but typically treat the rest with DCB.
Paul, do you ever use the vessel sizing feature, and is that beneficial to you at all, or do you use that?
I do. I mean, especially when angiographically it looks one way, and then on OCT, if I see a big distinct difference between vessel sizing that isn't obvious on angiography, which can happen a lot of times based on disease burden, it does have an impact on adjunctive therapy, follow-up balloon angioplasty, stent sizing, if that's what you're going to have to do. I'm the same. I try to avoid stenting. Stenting is kind of the bailout for most of the stuff below the inguinal ligament. But I do think it's very helpful for sizing and looking at some strange anatomy, especially if you're dealing with prior bypass and that kind of thing.
So, we've been talking about directional atherectomy, and we've kind of, I think it's kind of hard to argue with the fact that, image-guided directional atherectomy is so much more, informative, and will likely lead to better outcomes, even though there is not a head-to-head comparison. But, just the fact that intuitively you're not removing adventitia, which causes restenosis. So, I can't really say there's a head-to-head comparison, but it makes sense from a directional atherectomy standpoint. But let's talk about other atherectomy devices. Do you guys what situation would you use orbital atherectomy or rotational atherectomy or a laser ablative atherectomy? Paul, what are your algorithms for other types of lesions or other atherectomy?
Is that for me? I didn't catch that. So, okay. Yeah. I do. I rarely use laser. I've used laser a few times in some in-stent restenosis cases, and that's about the only time I ever use laser. I have used orbital as well as other directional atherectomy. I'm not as excited about the orbital atherectomy devices and the degree of debulking that I get out of that. I have used it a few times in the smaller vessels, such as the tibials. But again, I think it does more, it's a reasonable job of plaque modification or calcium modification rather than a true debulker. And unfortunately, I think the tibial vessels, where I see it used quite a bit, is it's kind of a different animal when you compare it to the SFA. And the restenosis rate in the tibial vessels, I think, is a completely different battle that we're going to have to be fighting. That's why I think getting a directional atherectomy device down in the tibial vessels is really a game changer if you can do it safely. And I think that's one of the things that makes you either have to be very cautious with other directional atherectomies in the tibials, or you have to see what you're cutting. It's got to be one of the two, because that's where you can get into trouble down there in those smaller vessels.
Jon, we were talking about adjunctive therapy, and Dish kind of talked about DCB and kind of mentioned drug-eluting stents. Obviously, below the knee, we don't have DCB. So what is your protocol for adjunctive therapy below the knee?
Yeah, so I've used DCB off-label. I've been surprised by vessel sizes, right? Once you start using intravascular imaging, you're pretty impressed with proximal vessel sizes, even in the tibials. I mean, it's easily 4.0 in a male. And I've even used DCBs off-label in the proximal tibials. I try not to stent distally, but I use tack stents as well. And now with BTK options with the tack stents, that's an option. I use coronary drug-eluting stents if I have to. But I try to limit stenting. And then, we're involved in some new trials with the STAND trial coming up with tibial stenting. And so we'll see what turns out to be best in that scenario. But proximal vessels, I try to use DCB still, and then DES as needed, or tack stents.
And then, Dish, what about access? A lot of people ask about access, crossover access, antegrade access. A lot of people are not comfortable with antegrade access, so they just kind of use a crossover technique. what is your, what do you kind of do with your access side? Do you kind of cross over everybody, integrate? What do you do?
I'm a crossover guy by and large. Yeah, it's a little more difficult, especially in the South, where our patients are a little bit heavier. So it makes integrated access a little more challenging.
All that good barbecue.
Oh, exactly, exactly. But I think the working lengths of the current catheters are more than enough to get us what we need in regard to effectively doing directional atherectomy. With the Pantheris device, looking at 110 centimeters, with SV looking at 140. So unless the patient's over 6 feet, you know, you usually don't have a lot of difficulty getting up and over in most people. But there are those specialty situations where you do need to get integrated access, but you know, that's the exception, definitely not the rule. So yeah, I'm definitely an up and over guy, and that's usually more than enough, 90+% of the time.
Thank you very much. So it looks like we've run out of time. I want to again take this opportunity and thank each one of you from the bottom of my heart. I know it takes a lot of time and commitment to set time aside from your families and prepare for something like this, and you really committed to educating physicians. And me growing personally, I learn something from you guys all the time when I talk to you guys. So I really appreciate that, and thank you very much. And thank you for the thank you to our audience that logged on today, and look forward to our next webinar. This has been recorded, so you can watch this again, tell your friends about it. It'll be posted on social media. We'll share this as well. Thank you, everyone. You guys have a great night.
Thanks. Have a great night.
Thank you. Good night.